Subscribe to our YouTube channel and press the bell icon to get the latest updates.
Hello and welcome to this panel discussion on the use of convalescent plasma for treating COVID-19. This panel discussion is titled Evidence Synthesis at Pandemic Speed, Convalescent Plasma and the PLACID Trial. To introduce the topic a little bit, we know that there has been a lot of talk of convalescent plasma for treating COVID-19. We've also been doing research and that has been producing results. With convalescent plasma, we saw that here in India during the second wave, the calls for plasma was going through the roof. Not only were doctors prescribing them, but patients themselves were asking for the treatment. But the PLACID trial showed back in October 2020 itself that convalescent plasma is ineffective in treating COVID-19. Other studies have since demonstrated the same result. So what went wrong? That is one of the main things we hope to discuss here, and we'll also be discussing the PLACID trial itself and the use of convalescent plasma therapy, its history, and what we've learned from this fiasco that was the response to COVID-19. We have here with us today 4 panelists. Dr. Jayanthi Shastri is the head of department at microbiology at Kasturba Hospital. She was a co-principal investigator on the PLACID trial. Dr. Anup Agarwal is a physician in New Mexico. He was the lead investigator of the trial and he was with ICMR during the trial. Dr. Swapnil Parikh is a consultant physician, author of the coronavirus book and a co-investigator on the trial. And we also have Dr. Aisha Soonawala, a consultant with infectious diseases at the Hinduja Hospital. I'm Sandhya Ramesh. I'm the science editor at ThePrint India. So I thought first, before we jump into the discussion, let's just talk a little bit about the science behind convalescent plasma. What is plasma? How convalescent plasma is technically supposed to work? I thought maybe Dr. Jayanthi, you could take this question and walk us a little bit through what convalescent plasma is theoretically supposed to do for COVID and what ends up happening.
Yeah, so thank you for putting together this very, very important topic on the use of convalescent plasma. And like you have titled it as pandemic speed, I think my thoughts date back to April 2020, when at record speed, with heightened enthusiasm, we all as a team made sure that we got the ethics approvals necessary for conducting this trial, because there was always a hope that something would work for COVID-19. And talking about convalescent plasma, basically it has a history in the use of convalescent plasma in infectious diseases. It dates back to about the 20th century when it was used for the bacterial diseases like diphtheria, scarlet fever, then pertussis, and a number of viral infections in recent times also. So what is convalescent plasma? Basically, it is giving preformed antibodies, like we say. It's like passive immunization, giving preformed antibodies. So when a patient recovers from COVID-19, the body produces antibodies in response to infection. And you collect the plasma of this individual, this patient, at 28 days post symptoms, and you transfuse this to another moderately severe patient and monitor the outcomes. Basically, it works as a pathogen neutralization. In simple terms, it limits the multiplication and neutralizes the virus, and therefore the effects of the infection would be minimized. So this is absolutely in a nutshell that what is convalescent plasma and how there is history about it and how it should be working.
So just to summarize, what convalescent plasma basically does is after a person has recovered and we take convalescent plasma from them, theoretically, it is supposed to provide us with temporary antibodies to give us protection while our body is producing its own antibodies. Do these antibodies also help produce more antibodies in any way?
No,
Okay.
they do not help. They work as a safe of phagocytosis, as in they enhance the capability of the body to engulf the invading pathogen. I would say it acts as a facilitator also when we talk of phagocytosis. So it acts in facilitation of virus neutralization, as well as these antibodies itself can cause pathogen neutralization.
Okay, got it. So that was the basics of how plasma works. So obviously we understand this is the theory and we do experiment with it and we try to trial it. Dr. Anup, could you walk us a little bit about through the plasma studies that we encountered, especially in early days? What were the studies that you encountered before PLACID and what after that, and what did these studies show us?
So the first thing is studies are of many types. Okay, the best kind of evidence is randomized control trial, and the least or the first evidence is a case report. So basically, you see a patient, you do something, and you say, "Oh, this worked." So that becomes a case report. It's one patient, one observation. It could be by chance, it could be because of the effect of the drug, but you don't know. So that's why we call it a case report. When you have many case reports together, you call it a case series, like 5, 10, 20 cases. We call it a case series. It also can be by chance, it can be because of the effect, but we don't know. Then the third thing is observational studies. So you look at large number of patients, either going forward, or you take out your hospital records. Say you saw 10,000 patients in your hospital, and you see that 5,000 got plasma, 5,000 did not, and you compare those two groups, and you see what happened. And if the people who got plasma, they lived longer, then you make a hypothesis that people who were getting plasma were living longer. So that is observational retrospective studies. There are similar kind of studies. The best one is RCT, which means that you are going forward. You are not looking at what happened, but you are going forward, and you have a prefix sample size of, say, 100, 200, 400, which is determined by statisticians. And in that, you give the drug to half the people and you don't give the drug to half the people. And you see the group which got the drug, did they do better or they did not do better. And this is called randomized controlled trial, and that is the best quality of evidence, and it is the only way you could say that a particular drug has any effect or not. So before Placid, what all studies did come? So it was actually on 26th March in ICMR we were discussing whether to study plasma or not, and we were thinking about it. And I remember seeing on 27th March there was a paper in JAMA, Journal of American Medical Association, which is one of the most respected journals, from China, and they had said that there was a case series, which means a few patients, of 5 patients who had gotten convalescent plasma. Until the time of the publication of that study, all of them were living, all of them were surviving. They may have been in the hospital, they may have been on a ventilator, but they all had survived for a good time of 28 days. So that gave us an impetus to see whether this can be a therapy that works or not. So that was the first trial or first case study or case series that came out. But
I'm sorry, when was this, you said?
27th March
March.
2020,
Yeah.
it came out. And so I think this was the first one, and this like helped catalyze trials all across the world on convalescent plasma. It got a lot of news reports, not a lot of coverage. The second one that I remember again was from China, of I think around 105 patients or 100 patients, and this was a randomized controlled trial, and this was sometime in May or June 2020. So this was a randomized control trial, which means it is very high quality evidence. But they said, but by then China's epidemic had stopped and they couldn't reach their sample size. So they said we cannot say whether it works or not. So it was inconclusive, but it was a RCT and it was pointing that it may work. The third one was in preprint, and I think it's still in preprint, which means that it is not peer reviewed, was from Holland. It was called Concovet Trial. And they had 80 patients, and their trial had to stop because in Holland, the pandemic had slowed down. Uh, and that was the third trial that we encountered. And they said they did not see any benefit of convalescent plasma. And then I think once we saw the China RCT, we did not look for much observational studies or case series because they stop having much validity once you have a randomized control trial. And then I think PLACID came, which was the first completed randomized control trial, and we were able to enroll 464 patients across 39 hospitals, so giving it a lot of generalizability across India. And what we did was we allowed it to happen in the most natural way. We did not control a lot of the factors. We were like, just do what you do, but we'll experiment with this. We'll give half the people the therapy and we won't give half the people the therapy. And it was the way it was being given in India. We did not say give it early, give it late, give it in serious, give it in more. So, but we said just give it in moderate, and it showed that it did not work. We used it in moderately sick patients, and it did not prevent progression to severe disease, or it did not prevent mortality. So yeah.
And other studies have subsequently since shown the same thing, including the Solidarity trial?
No, not Solidarity, recovery trial from England. So they've been the best people in the whole of COVID. So they did a trial on more than 10,000 patients, I think, and it was published in Lancet recently. And it showed that it did not work. Now, some people can say that they did not give it early, but giving it early is probably impractical, or is impractical in India. It does not have much translational value because we have a lag of patients coming to the hospital and then getting tested and then test results and then getting plasma on time. I think giving it within 3 days is impractical. So I think the recovery trial is very conclusive evidence that it doesn't really work.
So we have studies that have shown, well, at least one study that showed that it did work within 72 hours. And of course, like you said, there are all of these other problems of testing lag, and basically we lose the time window that we have, if at all we even want to give treatment at that stage. But my question is, even if we do manage to detect it and we know we have that window within which we can give the convalescent plasma treatment, do doctors actually prescribe the treatment at that stage? Is it not safer, or rather, is it not natural for us to assume that people would naturally tend to recover?
So you have to. I think there are two parts to this answer. There is a reality of our country, and there is a reality of science, and I think they don't match. So you look at a patient. There is so much stigma around COVID. People don't want to say that they have a fever. They don't want to come to the hospital. So there will be a lag of 24 to 48 hours. And when times are bad, the RT-PCR tests are not available. When available, they take 48 to 72 hours sometimes in most of the country. So the 72-hour timeline may be over for most of the people. Having said that, I don't want to be pessimistic. If you have someone and if you want to give it, you give it. But if you keep something like this in the guideline, you have to see the cost that the patients pay. How much, what percentage of patients will get it within 72 hours, and what percentage will get it after 72 hours? And if you do a cost benefit analysis, I think your costs are much higher and your benefit is much lower, and it's people who are paying out of their pocket, at least in our health system. So that's the first thing. I think one way it could be done is like, say, it could be run as a public health program in across say a very crowded area in Bombay or Delhi or Calcutta. If you have a very crowded area which tends to become a very high risk zone, what you can do is You can run active surveillance. You go and test them weekly, a good number of population, and you see and you catch them before 3 days, and you give the plasma then and there, and you can stop the epidemic. And that is how you can do passive immunization. But that is a very different strategy, a very different public health program, and it has to be run in a very deliberate manner. But that is the only way I think that that piece of evidence could be used in our country.
That I do want to touch on this passive immunization a little bit later, but since we were discussing studies, I thought I could just go on with that. And maybe Dr. Swapnil, you can answer this. At what point did it become kind of pretty evident that, we should probably stop with plasma? And I'm asking before your trial results came out, PLACID trial.
PLACID was one trial. So I wouldn't say on the basis of just one trial, you'll say, let's stop. I think what was starting to happen was it was being used extensively outside of clinical trials. And we've seen this problem before, right? So I'll just backtrack a little because you may have some people who aren't necessarily doctors also watching. What we were talking about earlier, the difference between observational research or the difference between just off-label use and a clinical trial. So it's a slightly oversimplified example, but let's imagine, so for context, most mild and moderate COVID-19 patients recover. It's a subset, a percentage don't, and they get severe. But the absolute numbers are large because it's a pandemic virus that's affecting so many people. But the vast majority as a percentage do recover. So let's say I go into a COVID-19 ward, which has mild or moderate patients, and I just clap my hands every day. And my hypothesis is that by clapping my hands, people are going to get better. And at the end of it, I see, okay, 95, 99% of people in this ward got better. So clapping my hands has a therapeutic benefit in COVID-19, which obviously would be ridiculous. No one would accept that as science. And that's what can happen in an observational program, or when they don't have an appropriate control group. So if you ask me, when did it become clear that we probably shouldn't be using it off-label the way we were? I think pretty early, I would say even earlier than PLACID. The way it was being used off-label outside of a clinical trial, I think was inappropriate. Yes, plasma therapy is safe, but in a pandemic situation, when we don't have much evidence, we have a duty to generate evidence. I would say it became clear pretty quickly that we should be using it in clinical trials and not outside. If you look at the US, for example, they administered so much plasma, but they just did it off-label. They have so many observational studies. They could have had a recovery trial for convalescent plasma with a large amount of data very early, but they didn't. So to answer your question, I think even after PLACID, there was some room to continue clinical trials. Maybe as Dr. Anup suggested, even now there is room to conduct clinical trials. Something we could do is, let's say, in a cohort of individuals who are 85 plus, who have an extremely high infection fatality rate, in some places where vaccines haven't been rolled out. So a 15% fatality rate. Or in individuals who are 65 plus, who have diabetes, heart disease, other risk factors for very severe disease. If a family member has COVID-19 in that family, immediately test all the elderly relatives, all the high-risk relatives. And if anyone is positive but still asymptomatic, then you could administer convalescent plasma there and see what happens. You could do a trial like that. So I think there's still some room in clinical trials to use convalescent plasma. I'm just not sure there has been room to use it off-label as has been used for a very long time, probably even before PLACID was completed.
Okay. And so along the same lines, can you also tell us a little bit about what the PLACID study found exactly? Could you just walk us through how the study was conducted, what its conclusions were, and also how did it impact recommendations?
I think some of these questions also I'll ask Dr. Anup to chime in, because
yes, please,
we'll be able to contribute a lot here. But essentially, so like Dr. Anup was saying, it had two groups of individuals. one group who was given the best standard of care plus convalescent plasma, and another group that was given best standard of care without convalescent plasma. And this group, it was randomized. And what we found at the end of PLACID, so we were looking to see whether patients would have, who got convalescent plasma, would have a better outcome in terms of a lower 28-day mortality. So less people would die, statistically significant number of people would be saved, and that there would be lower progression to severe disease. And then there were other endpoints like clearance of the virus at 7 days, decrease in inflammatory markers, symptomatic reduction in symptoms like fever, cough, shortness of breath, fatigue. And and a post hoc analysis, we also looked to see whether there was any benefit from higher antibody titers. So if it was given in people who it was given earlier, whether there was a benefit. And there was no difference. There was no difference in mortality. There was no difference in progression to severe disease. There was a difference in clearance of the virus in that more people who received plasma cleared the virus at 7 days as compared to those who didn't receive plasma. And then there was subjective symptoms. There was improvement. For example, fatigue and shortness of breath seemed to resolve faster in the group that got plasma. But again, this is subjective and could be prone to bias. But in a sense, it was the first clinical trial that showed that convalescent plasma did not offer mortality benefit. Another very important finding, I think is very relevant for our setting, we actually found the donor group, so the individuals who donated plasma, had on average lower neutralizing antibody titers than the individuals who were receiving plasma. And another important finding was that the individuals who received plasma and did not receive plasma, there was no significant difference in their neutralizing antibody titers. So not only was the recipient population, generally because they're older and had more severe disease than the donor population, they had higher neutralizing antibodies to start with than the donors, but also administering plasma did not really increase the neutralizing titers between the two groups. I think these were two important findings. If Dr. Agarwal wants to add anything.
No, I think that was very well summarized, and I think you covered all the points. I would want to add that in March 2020, plasma was coming up as a very attractive option, and policymakers in ICMR had two options: to go the US route or to go the route that they took, which is, should we just allow plasma to be used off label and collect data and have an observational registry kind of a thing, or do we do a trial and get an answer? And I think they took a very bold step, because say like in September or October, we learned that plasma worked, and then we say that, oh, we were not giving this drug which was useful for the last 6 months, then that comes with a lot of moral obligation. And they were very I think they took a very good decision of studying the drug and getting a research answer. And we were able to complete this trial much before anyone else, even though it was a much smaller trial compared to recovery. But I wish we would have done the same for ivermectin, for hydroxychloroquine, for other drugs. Like Solidarity helped us study 4 other drugs, but we never studied doxycycline. We never studied so many other things, itolizumab. So I think we could, and at ICMR we did have the capacity. I just don't know why we did not do that. That was an opportunity missed.
Can you also tell us how you think the PLACID findings impacted recommendations subsequently?
Okay, that's a tricky question. So now we know 7 months after the trial that the convalescent plasma is not in that protocol, which is the one pager that the ministry releases. You can always, you could see in June that it started appearing on that one page. They never recommended it. They said this could be tried off label. They used all sorts of language to protect themselves. But what it translated into is people were just giving it. And And we saw this happen because we were doing the trial and we were seeing that patients were not asking, and it was easy to enroll patients in the control arm. And then you would have patients who said, no, I want the plasma because it's on the treatment protocol. Patients have started reading it. So I think people started asking for it, people started reading it. And then once you put something on a guideline, it becomes very hard to remove it. And then once PLACID came out, so there are three stakeholders mostly who make these guidelines. Uh, one is the National Task Force, uh, which has in which AIMS has a very loud voice. The second is AIMS New Delhi, and the third is the Joint Monitoring Group of the Director General of Health Services. And I think they all sit together and decide on this. And when like policymakers sit, they don't only look at the evidence, they look at the political fallout. They also look at like what are other countries doing, what is WHO saying. I think there is a lot more in their minds than just like what the evidence is. And I think there was a time when they decided that we will remove it from the guideline. And this is me knowing from the periphery. And then I don't know what happened, but ICMR came out with its own guidelines, which you can see. There was a separate guideline by ICMR on plasma where they started saying we should give it early, we should have high titers. But then again, it doesn't help. And then the single pager, it always had all the same recommendations. And then I think a week ago, when recovery trial came, I think they started respecting PLACID trial more, and they took it off. But it's very hard to say why it was not removed right away. Yeah.
Right. The process always seems to be at a lag and follow through a little while later after the evidence comes along. Dr. Aisha, I wanted to ask you, given your experience with infectious diseases as well and the response to COVID-19, can you tell us a little bit about what you think happened during the second wave? Why did calls for plasma peak? When did the clamor start? And despite the evidence, why was there so much fuss around plasma as the wave started, as the numbers started climbing up?
I think Dr. Agarwal sort of summed it up very well, in the sense that there were mixed messages coming from the Delhi health authorities that issue these directives, and I'll call them directives, not guidelines, because they're, as he said, a flyer, a single page. And we have to understand that this sort of percolates right from the top to the peripheries, to the smallest centers. And not just this directive that came out from the health authorities, but we even had a lot of very senior people involved in plasma therapy in some sense, in some trial or the other, going on record, some heads of institutions, going on record to say that ICMR hasn't banned plasma therapy and they still allow it as an off-label compassionate use because we don't think we're in a position to give up on it yet. Still others saying that the PLACID trial was clearly done in moderate illness, and just like we're talking about the monoclonal antibody cocktail now, plasma analogously would work better in mild illness. However, having said that, most of the clamor for plasma was in patients who had already crossed that mild illness period, as we just spoke about. And although my center has never done plasma and we've never been involved in a plasma trial or in using plasma really, I was aware of a lot of, as you said, a lot of clamor, a lot of desperation. And I mean, that's natural. It's not just with plasma. We've seen it with multiple other therapeutic interventions, with multiple other drugs, because that period of a few weeks, a month or two ago, when there were no hospital beds, there was no oxygen, led to, a desperation of sorts, both with the clinicians as well as the patients. And that desperation leads to, scientific exceptionalization. So you're looking for limitations in the study. You're searching for, ways to do things differently. not just you, but even the media and the public and everybody. And I think that's what happened, and it's a natural curve as the surge goes up and comes down.
Would you think maybe the calls for plasma might have been a little bit more tempered had a response to other infrastructural needs like oxygen and maybe just regular standard care? Had that been a little better, do you think people would be going after plasma a little less?
Again, I say not just after plasma, but after just about anything they could get their hands on. There was the same clamor for remdesivir. There was the same clamor for tocilizumab. There was the same clamor for hospital beds and oxygen, as we all remember it, And plasma was just one of those things. It's just that we're discussing it today because we had a trial out there, a national trial, the first of its kind with the largest numbers, showing us the futility of it. And, the frenzy over it was still the same. And I know that what's sad about it is that the public took so much pride in the way communities came together. Alumni of universities, IIT, IIM, helped their friends who were abroad, whose parents required plasma, and they pooled in their sources and their energies, and they got it from all over the place for them. And this was such a waste of energy and resources. We also had plasma banks calling for donors. So there's this kind of guilt on the relatives. There's this kind of guilt on people who've recovered from COVID to donate. And you actually have, as late as April, plasma banks calling out to people who've had COVID and saying you have the potential to save 2 lives if you donate plasma. NGOs in collision with the plasma banks, of course, unknowingly. And clearly, this was mixed messages coming all the way from the top and percolating to the bottom.
Right. And we saw this on social media a lot, everything that you just described, plasma banks being set up, and also the guilt. That's a really good point that you mentioned, because I personally did see a lot of tweets where people said, I have recovered and I'm fine, and I've only recently recovered. I want to do something helpful. I feel really helpless seeing everyone around me. And it's, again, like you said, it's just inconsistent messaging. But has plasma ever been useful in infectious disease? I know there are different kinds of plasma, and we'll just talk about that in a bit. But I wanted to just ask you, has it ever been successfully used in infectious disease treatment before?
So as Dr. Shastri pointed out right in the beginning, plasma is perhaps the most age-old therapy that has been tried and tested. Right from, there are records of plasma being used even during the Spanish flu 100 years ago. And then again, for other things like diphtheria and scarlet fever and all sorts of things. Has it been used successfully in modern medicine in the past few years? Yes, again, during the earlier SARS and MERS and Ebola outbreaks and stuff, there was talk of it, there was use of it, but there has never been any large-scale sort of well-conducted trial that has shown sort of meaningful outcomes, meaningful clinical outcomes.
Right. Even for Ebola, I believe it did show promise, but then the monoclonal antibodies were much more effective. So we just switched to that instead and just completely stopped with convalescent plasma.
Right. And that's exactly the conversation that we're steering towards here, that there is perhaps still a role of a trial in really early in people who are at higher risk, which is exactly what is being recommended for the monoclonal antibody cocktail right now, So it's sort of a repetition of what has happened in the past.
And that's actually a good segue. And I thought we could go to Dr. Jayanthi. Dr. Jayanthi, could you tell us the difference between convalescent plasma and monoclonal antibodies?
Before I answer that question, there is one very important thing which we are missing is the donor screening for plasma. So that was actually a major challenge when we started convalescent plasma therapy. Getting the right kind of donor was a huge challenge for us. It was very easy to say that we should, go for a patient who was symptomatic. And there were certain symptoms also mentioned. However, we did have, so we are actually talking about April and May 2020. At that point, there wasn't enough literature available. All what we knew was that asymptomatic individuals do not have a good antibody response, whereas symptomatics have a good antibody. Now, the good is the one which we couldn't define. And at that point in time, we did not even have adequate antibody tests to check whether the antibodies are substantial. So, donor screening, which patient to take, time of collection, whether most of us do have an apheresis machine in the blood banks, which was very helpful because apheresis gives us a good yield of the plasma, and the RBCs, they, go back to the patient, to the donor. So that was useful. However, another challenge was the lockdown. Because of the lockdown, we had to arrange transport also for the donor to come to our blood transfusion unit for donation. After the donation, we wanted to do a pre-donor screening prior to collection of plasma. So fortunately for us, at our setup, I wouldn't say that for 39 centers in the country, because everybody was grappling with the antibody tests, because at that time, what was available were rapid tests, which had compromised sensitivity and specificity. We had ELISA tests with not great sensitivity, but at our center, we managed to get the Abbott NC Clear, which is a chemiluminescence, and the Public Health England report had about 92% sensitivity. So we were very confident that, and there were early reports from the company itself that, if you have an index of 3.5 to 4, it translates into almost 1 in 80 neutralizing antibodies. So I would like to share here that at our center, we used to do a pre-donor screening. We used to run the CLIA test, give the report in 15 to 20 minutes, and then do the donation, take the donor's plasma only if the index was beyond 3.5, which we used as a cutoff because of the early reports from the company. So here I would like to highlight that when we talk of passive immunity in the form of preformed antibodies, which seems to be like a magic bullet, we need to also know the quality of the antibodies, the quantity of the antibodies before we go in for any therapy. Now, this was not available to us. And the neutralizing antibodies which were done at NIV, the reports came much after the trial closed. So we were clueless about the quantity of antibodies in the donor at most centers other than ours where we followed this. So basically, this is what I would like to say, that dating back, we didn't even have good quality tests. Even today, we don't know neutralizing antibodies to what extent is adequate. Now, when we don't know the adequacy, I think somehow that is a caveat in any therapy. And talking about convalescent plasma therapy in 2021, after the variants have been identified, that the big question before us is whether a plasma from the donor of X variant is going to be effective against the Y variant. That is a big question in the context of variants. So this was something which I thought I must share. And talking about answering your question about convalescent plasma and monoclonal antibodies. Convalescent plasma, you just have to collect by the plasma apheresis, and directly it can be matched and transfused in the recipient. Whereas in case of monoclonal antibodies, there are companies which purify a specific, suppose it is a monoclonal antibody against the S1 RBD. Then it is specifically, there are ways and means of purification of this particular antibody, and very specifically It is, there are methods to do so and made available for the treatment.
And how does the functioning and the mechanism of action itself, how does it differ between the two?
The mechanism of action will be, monoclonal antibodies will be very specific. Because when we talk of convalescent plasma, it can have different kinds of antibodies to different epitopes of the virus. Whereas a monoclonal antibody is very specific and it will definitely add to the specificity of the therapy.
Okay, got it. And you had mentioned apheresis. For those who are unaware, apheresis is basically removing blood, separating blood components, and then retaining the plasma, and then putting everything back into the bloodstream. Going forward, I think I also wanted to ask, I'm not sure, I think whoever would like to answer this, can you talk a little bit about where else plasma is used? Not just convalescent plasma, but what is the use of plasma in general in medicine, just to get an idea? Maybe Dr. Jayanthi only.
See, as far as COVID goes, I have just come across a very good study in the clinical infectious diseases, which is published in April 2021. It holds promise in individuals who have severely impaired humoral immunity. So there, in fact, the convalescent plasma therapy holds promise. And I'm sure that is one possibility we should explore and take this whole therapy forward. As far as the convalescent plasma therapy in autoimmune diseases, I think this question can be taken by the others.
Sure, I can.
Yes, please.
So, just to explain to some of the viewers who aren't necessarily scientists or doctors, whole blood contains certain cells and it contains plasma. When we centrifuge blood, you'll see a yellow layer, you'll see some RBCs, and we'll see a buffy coat. So, plasma is essentially the yellow component, it's what the cells are suspended in. This plasma, so fresh frozen plasma, for example, we use in coagulation disorders, during massive blood transfusions, bleeding, specific coagulation factors when they're missing. We can take components out of plasma and refine the plasma and give those. Plasma has been used in other infectious diseases. Other components, so like hyperimmune immunoglobulin, has been used in rabies immunoglobulin, in tetanus immunoglobulin. Interestingly enough, IVIG, which is, it's not like plasma, but it's the immunoglobulin, the same component that we are transfusing plasma for. IVIG has been used in GBS, in many conditions. Interestingly, it's also one of the treatments used for WIT, vaccine-induced immune thrombotic thrombocytopenia, which has occurred after some of the adenovirus vaccines. So plasma in itself is very important in medicine, is very important in the body. In infectious disease in itself, hyperimmune immunoglobulins have been used. Plasma therapy has been used, convalescent plasma therapy has been used in the 1980s for Argentinian hemorrhagic fever, where one RCT did suggest that there was a mortality benefit. So wide variety of uses in medicine.
And I believe for autoimmune diseases, it's sort of like a shortcut where you just take a large bunch of antibodies out and then put back fresh plasma inside.
Right, plasmapheresis, again, slightly different from the way we're using convalescent plasma. Plasmapheresis has been used in a whole variety of conditions. And that's when you're essentially removing a certain component and then you're adding in fresh frozen plasma.
Right. So, Dr. Aisha, how do you think the situation is now, ever since plasma has been taken off the protocol? Has the usage of plasma, has it definitively gone down in the country?
Again, Sandhya, difficult for me to comment on that because I'm not at a center that has ever offered it or has ever done it. These were just people asking me about it, hearsay, people from in the community and stuff. But it's just the natural course of the surge coming down, the numbers coming down in Mumbai, the clamor for hospital beds, better availability of hospital beds, better availability of other things which are, perhaps more, which we have more evidence for. So again, saying that was an exceptional time when the community was just desperate for anything it could get its hands on. So I'm not sure whether removing it from from the Ministry of Health directive has really made a significant impact right now in the last couple of weeks, or it's just been the fact that the numbers are waning.
Right, it just coincided. Would anybody else have anything to add to that?
I can.
Yes, please.
I think there are a few things that we should learn from this, the plasma and the pandemic. First was, I think it was very irresponsible of Mr. Kejriwal to come out in April 2020 and say, "Oh, we are doing trials on plasma and it works." I mean, the ILBS study, it's published, it doesn't work. But he made a very irresponsible statement. So that general public took it on. I mean he can make statements, but he comes with a lot of responsibility, and I think those statements were not very responsible. The second is, I think in Maharashtra, what they did was pretty unprecedented. Like, the chief minister is inaugurating a trial on convalescent plasma, the Platina trial. I think that for me was pretty weird, because once you have such a powerful person inaugurating a scientific trial, I think the scientists may not be able to speak their mind. They may not be able to think right, and the process may get compromised. And their question was wrong. I mean, they were studying it in severe disease. We tried telling them, don't study it in severe disease. Study it in mild patients. That's the indication we are getting from our initial results. But I mean, it could have something to do with the politicians inaugurating a trial. I mean, it's unheard of probably in most other countries. So that's the second thing. The third thing, I think, the science in COVID till now is pretty clear. You need a very few things which work. You need oxygen, we know that. You need a responsible doctor, a responsible nurse, a hospital bed, we know that. And we know that we need steroids, and we need steroids in limited doses, and we need anticoagulation, and nothing else has shown to work very well. I mean, the other therapies, they come with their limitations, and but these are the things we should have scaled up, because we should have been ready for such a surge. The amount of effort that the community put in, like, as Dr. Sunawala said, like, people from IITs, IIMs, like, coming out with plasma apps, plasma this, plasma that, or like same thing for remdesivir. If we put all our community efforts, all our efforts into these three or four things, we could have had a much better response if we built our health system just around these three or four things, which we knew worked. But the main thing that was missing was good guidance from the top, and that's why people were confused and they tried to get anything and everything. And I think a lot of community energy was wasted, and a few more lives could have been saved.
Right, that actually sort of brings me to my next question. I wanted to ask each of you what you thought the biggest lessons were from this pandemic, and the response, especially when it comes to adopting treatments before evidence is established. I thought we could just touch upon that and just hear from each one of you before we sort of move on to how to evaluate evidence during a pandemic. Dr. Swapnil?
Lessons. Important to state, the pandemic isn't over yet, so we may still have lessons to learn. But I think what has become very clear is that we have to lead policy with science. I think what has also become really clear is that we need real-time credible data. And there have been a lot of blind spots. We don't know how many people have been infected in this country. We don't know how many people have died. We don't know what the age or geographic distribution of mortalities is. And when you have those kind of data blind spots, it becomes very difficult to respond. What data we do have, it's not in real time, so our response is delayed. And then we see that even when we do generate actionable data like we did with PLACID, for some reason that does not immediately translate into benefits into the health outcome. So at least for me, I would say that real-time credible data that can impact health outcomes is a lesson we should take away for the future. And I don't mean just in clinical data, I mean epidemiological, genomic, across the board. We need better data and we need it real time. And we need to be able to use it to impact outcomes.
Dr. Aisha?
I think there has to be a change in there has to be a change in the culture of scientific synthesis, in wanting to look at the science behind policy making. And that's not just for the policy makers or for the health authorities, but involving institutions, involving clinicians. Very little emphasis is paid throughout our medical education on actually understanding or appreciating evidence-based medicine. We still, to a great extent, go by eminence-based medicine, where the last word is always of the senior most person in a department or in an institution. Yeah, and as I said, the culture of encouraging that, emphasizing that at teaching institutions, at teaching hospitals, has to be really sort of reiterated and emphasized to a far greater extent than it is today. Of course, institutions like this are very few in the country, but they can then influence the community at large.
And this also has to do a lot with our culture itself, like you said, eminence-based.
That's true. I mean, that is a major change that I think we all need to sort of look at and understand as to where things probably went wrong, especially in this second wave,
Right. Dr. Jayanthi?
So since I work in diagnostics, the one lesson which I have learned through this pandemic is we have to use our common sense, because there are so many things which are unknown. So when we are dealing with unknown, somewhere we have to come up with some rational thinking in terms of the requirements and the appropriate methods. And probably we have been able to sail through because of that. And the other thing which I get very disheartened working in India is that the best quality diagnostics are not accessible to us for reasons I do not understand. Today, if I have to have a surrogate virus neutralization test to detect neutralizing antibodies for SARS-CoV-2, the only kit which I have is a GenScript assay, whereas the developed world has access to better kits like Monogram and other things. And doing a plaque neutralization test or any other test for neutralizing antibodies is far-fetched because it is available only in research labs. So I think it's high time that we also have access to the best quality diagnostics. And I'm sure if there is enough people like us, like-minded people come together, we should be able to get it.
Can you just explain a little bit about how neutralizing antibodies are detected and how we differentiate them from other kinds of binding antibodies and non-neutralizing antibodies in the lab?
Yeah, so basically, as I told you, that we have systems for identification of binding antibodies. So we can detect the nucleocapsid antibodies, which appear very early in an illness, and they wane with time. So if you say about 2 months of the symptoms or the positive PCR, you get the nucleocapsid antibodies. And after 1 month, the binding antibodies which develop are the S1 RBD, that is a receptor binding domain. So we have systems in our lab to detect the binding antibodies by the chemiluminescence method. We have the Abbott system as well as the Siemens S1 RBD. Now, so I have been a part of the largest sero survey in Mumbai. So what we did was we did correlate the presence of the binding antibodies with a surrogate virus neutralization test, which is the CPAS neutralization test from GenScript. This is a US based emergency authorization it has received for research purpose. It is only for research purpose and not like a diagnostic test. So what we have seen is that in a fair amount of patients, even if binding antibodies are not present, we do see the presence of neutralizing antibodies. Now, a recent paper has come that the CPAS test also detects the non-neutralizing antibodies in some cases. So I think I can confirm the test results only if I have access to a BSL-3 lab where they do the serum newts or the PRNTs. But as of now, what we are doing, especially for post-vaccination cases in our own hospital, I am from a very large tertiary care hospital. We have 1,800 beds. Number of healthcare workers have been vaccinated. And so we saw that post-vaccination in 60 healthcare workers, there was development of neutralizing antibodies using the CPAS neutralizing antibody test above 30%, even when in 5 of them there were no binding antibodies. So we take it as a correlate of immunity. And if you ask me how much of neutralizing antibodies is called as adequate, I have no answer, but still there is no world literature available for adequacy.
Right, and we hope that time will tell and we'll eventually get data over the next few months, hopefully. So we're about 1 hour in. I guess we have another half an hour, and there are just a few concluding things and the main takeaways from what happened with plasma during this. So the first thing is, how do we evaluate emerging evidence, especially during a pandemic? Because we saw that there is, first of all, there's a lot of contradictory evidence. There's a lot of studies conducted on small sample sizes. There are lots of just observational studies. So what is a very cautious and at the same time rational way to go about evaluating emerging evidence? Dr. Swapnil?
When we're thinking about evaluating evidence, I think Dr. Anup touched upon the different kinds of studies. I think that's really important. The evidence pyramid, which starts with animal studies and in vitro work, and then has case studies, case reports, case series, case control studies, cohort studies, and then randomized control studies, meta-analysis, systematic reviews. So what is the kind of evidence you're looking at? But a few questions that can help. So is the evidence you're looking at up to date? So are you looking at something that's relevant to our times and to the disease in question? For example, with plasma therapy and COVID-19, if we're looking at a study on influenza, Ebola from, let's say, 10 years ago, is that relevant today and to this disease? What is the source of the information? I think that's really important. Is the information coming from WHO or US CDC or something like uptodate.com, trustworthy source? And is this source in turn citing the references, the place where the evidence has been synthesized or presented from? I think these are some of the questions we can ask while evaluating. Another important thing is, has there been a comparison group? So I guess this comes a little under randomized control trials, but what has the outcome been compared against? So for example, let's say we look at plasma therapy. In one group is mostly young adults, and the other group is elderly. So there's going to be a difference in mortality between the two groups anyway. Are the two groups matched? Have they been randomized? When we're looking at evidence from people's point of views, sometimes whether the person is an expert, their credentials, what their priors are, do matter. But equally, if they are an expert, do they have a bias or a conflict of interest? For example, someone who runs a plasma bank and stands to financially benefit, are they giving you an opinion saying that yes, let's go ahead with plasma therapy? I think these are some of the important ways to evaluate evidence.
Dr. Anup, do you have anything to add to that?
Can you repeat the question? I will. Sorry.
No, my question was, how do we evaluate emerging evidence, especially during a pandemic?
Yeah, I think that that's not very hard. It's pretty easy. If you look at what the US has done, NIH has a document, and they basically look at all the studies which are incoming, which are available in public domain, and they keep updating their guidelines up to date, which is a very widely used scientific resource. You can see they keep updating their guidelines based on what evidence is emerging. WHO is doing that. I personally just follow like what these are doing. It's not a very, it's there's no rocket science behind how to evaluate emerging evidence, because the emerging evidence is in public space, and you can look, and there are ways to see like whether the study is good or not, and whether we should use this study to guide ourselves or not. And then that's not hard. People have been doing that. For what I would like to add is that evidence is supreme, and we should use that. But also, in addition to evidence, we should put the social context also in mind. At a time when we are struggling for oxygen, I think we should look at more. So I think like when we are strained for resources, our evidence should be in line with what our resources are. A drug like, say, like a tocilizumab, it may work wonders and it may save lives, but that is when you start doing a cost benefit analysis or a cost effective analysis, and see whether at a population level this will lead to more bankruptcies or this will save more lives. So I think in our scenario we should also put the social context in mind, because what can our government hospitals offer at scale? What can our people pay for at scale? I think that also has to be put in context. So in addition to evidence, the added responsibility that a policymaker or people making these guidelines should also have is putting the evidence into the context, the socio-economic context. Thank you.
Dr. Jayanthi, along the same lines as this, when it comes to evaluating evidence, we also did have evidence that showed that plasma could potentially be dangerous, the use of convalescent plasma. We found that the use of convalescent plasma in chronic infections could result in potential new variants and mutations. And there was also Project Platina that was launched in Maharashtra. Yeah, I can see Dr. Aisha agreeing. Yeah, this was this was supposed to be the world's largest convalescent plasma trial, but it was stopped early because data indicated that patients enrolled in the plasma arm were dying at a faster rate. So my question is, when we have evidence like that, how do we evaluate that kind of negative sort of findings that could potentially be alarmist while being cautious of what the findings suggest?
Actually, Dr. Anup has already answered this question, The Platina trial, it came up much after the initial results of PLACID trial were available. So if you ask me why did they do it, and he said, there was a word of caution also. And I have no idea as to why they went ahead with it. But I can only say that our hospital also participated, probably because we are a tertiary care hospital in Mumbai and we had already participated in the PLACID trial. But I don't understand the logic behind that.
Okay, that's it was concerning because even the findings indicated that patients receiving convalescent plasma were dying. So why were we not becoming more alarmed? Dr. Aisha, I'd love to hear your opinion on this as well. These findings came out in January. The trial was stopped in January when the investigators realized people were dying. But our second wave came much later and people were still asking for plasma. So what happened to those findings? Why was that not at the forefront?
Again, there was a lot of talk of convalescent plasma preempting severe illness. And so during the second wave, the frenzy was to acquire convalescent plasma and give it to your relative, friend, loved one before he developed severe or critical illness. And that's where the pleas came in from the doctors to the relatives to run around and get convalescent plasma because their loved one was potentially going down the path towards severe illness. But I think by the second wave, most people were informed that there was a critical point up to which they were going to try it, and thereafter perhaps it was not useful. And of course, there will always be outliers who do things at different stages of illness. But that couldn't be accounted for, and that was not rational. So I can't really comment upon it. But there was a much greater concentration of efforts on the group of patients who had the potential to become more severe, like the ones that they chose in the PLACID trial, even though the PLACID trial didn't really show benefit. That's an important point that everybody's been raising, and for all of us, this has been a tremendous learning curve, because from just being, from a clinician standpoint, from just being somebody who in the pre-COVID era, who sort of discussed journal articles in an institutional meeting or whatever, for the first time as a society, not just us as a medical fraternity or community, the entire society at large had open access to preprints, to non-peer-reviewed, poorly conducted evidence from all across the world, and with no knowledge or training or expertise in their analysis or interpretation. And as we went along, I'm now part of something called the COVID India guideline, which has been now sort of doctored or set up by CMC Vellore with a lot of help from the WHO experts and everything. And while we're going about synthesizing the evidence and interpreting it, you realize how important a grade system is in sort of creating guidelines, how important the main PICO questions are. There's a PICO modeling. And that is something that every one of us as clinicians needs to apply when we're reading any trial or study. So the questions that have come up here is the population, that's the PICO modeling, which is quite simple really. Is the population of patients that I'm talking about the specific subset that has been studied in this study? For example, all the clinical trials, all the RCTs on ivermectin have never identified a subset of patients. They've just looked at COVID-19 asymptomatic to the most severe and said that ivermectin doesn't work, which it probably doesn't, but it doesn't apply to any specific subset. It's too heterogeneous a population. What is the intervention that we're talking about? There has to be a specific intervention. What is the control arm? So if you have or what is the comparator arm? So if you have a comparator that is effective and that is cheap and affordable, then is there really any purpose in trying something different or new? What are the advantages that come with it? And finally, what is the outcome? That's the most important thing for me as a clinician. Does the trial question or the study question hold a clinically meaningful outcome for me? Does it matter to me that the PCR became negative at 7 days? Is it going to change anything in the course of treatment? Does it matter to me? And these can be dynamic things. Does it matter to me that the patient spend 2 days less in hospital? Yes. If I don't have hospital beds, if I don't have, if I have other patients who are far more serious, who require hospital beds, that's an important outcome for me. But various trials have been manipulated to meet outcomes, meet secondary outcomes. For example, the Favipiravir trial looked at as a positive trial when it didn't even meet its own primary endpoints, but met some secondary endpoints which were really of little value. So that's something that we as clinicians, we as physicians have to start being cognizant to.
Yeah, that is understandable. That makes a lot of sense. Am I still here? Oh, yes. I'm so sorry. My screen got stuck. Thanks so much, Dr. Aisha. And that sort of brings us to the end, towards the end. Before I let all of you go, I did want to ask one concluding question to each of you. Maybe Dr. Anup, you could start. We are now seeing numbers declining, and it appears that we're coming towards the end of the second wave. Going forward, of course, we do expect more infections in the future, potentially more waves, and so we've discussed at length about lessons that we learned from a public health perspective when it comes to the pandemic response. I also wanted to ask you, each of you individually, was there something over the course of both the PLACID trial as well as just in the past 1 year that you learned in your work that you were not aware of before, which has made a definitive difference to you? Dr. Anup?
That's a hard question. I have to think. But I think one obvious thing, I think two obvious things that I talk about is first is evidence to policy, policy to practice. There is a lag, and even if there is a crisis, I think there is a lag. I'm sure doctors are still using plasma. So that's first. And then the second, I think a lot of scientists or people who study are married to their subjects. In India, the biggest proponents of plasma have been blood bank specialists. Or like in the US, you see this group of people from Hopkins led by Arturo Casteval, or the people who did plasma. Like even after so much evidence, they keep saying it will work, it will work, it will work. So basically, scientists shouldn't be married to the evidence; they should be married to the cause. And I think that was a big learning point for me, because negative studies don't take you very far. If plasma was positive, I would be world famous, but it was negative. So like negative studies don't take you very far, and people get married to their subjects. So that is something. Yeah. Thank you.
Thank you so much, Dr. Anup. Dr. Jayanthi?
As far as my experience goes, I would say that in Mumbai Municipal Corporation, we got excellent support from our administrators. So that was very, very important for us in our own daily decision making, as well as helping the policy planners. So when it came to the PLACID trial, you won't believe it is a call which came from the municipal commissioner that do whatever is required to get the ethics approval as fast as possible. He is an administrator. He doesn't even understand that ethics involves, calling a meeting, discussing, seeing the pros and cons. But I would really appreciate the way all our administrators had the right attitude towards bringing out the best amongst public health officials from the labs. And now, in fact, they are very proactive in setting up genome sequencing also in the lab. So I feel the journey has been very heartening.
Dr. Aisha?
Well, I think one thing I've learned individually is that I have made my own mistakes in the past year, and I'm going to continue making mistakes as I go forward and I learn more. But one very important thing that I've taken from this is, yes, the COVID cases have come down, but there will always be room for. Currently, we're dealing with the post-COVID complications, especially the post-COVID mucormycosis. And clearly, this is a year for ID physicians, for infectious disease physicians, where in a deluge of post-COVID infectious diseases at the moment. But what I've learned is that whereas there is always room for observation, for clinical expertise, there's always room for experience. We just have to come together as institutions. We have to come together as governing bodies, as bodies from various specialties, and perform good quality, well-conducted clinical research in our country. Because we have the potential to do it, and we certainly have the numbers and the cases. And we have always been, we've tried to produce studies of various sorts, but low quality evidence, low certainty evidence, poorly conducted trials are a waste of time, a waste of resources. They're unethical.
Right. Thank you, Dr. Aisha. Dr. Swapnil?
I think for me, one of the learning experiences through this pandemic has been to put two things first in research. Of course, evidence, which has been reinforced during the pandemic, but the second is collaboration. So I think before the pandemic, I had not looked to collaborate with so many different people, and the ability to connect with researchers across the world, with a lot of different people, Dr. Shastri, Dr. Anup, work on so many different research projects. That for me was a great teaching moment because I learned so much from those experiences. Yeah, in terms of evidence, for me, but I think also for all of us, something that we can take away from this is I think sometimes there is this tendency to feel that during a pandemic, desperate times call for desperate measures. And I think if there's one thing that this pandemic should highlight for all of us, is that during desperate times, we should turn to evidence-based responses that don't abandon scientific reason. Because it's very easy to get caught up and feel, and it happens to all of us, it happens to me as well. We want our patients to recover. Like Dr. Anup was saying, you might be married to your expertise and just want to be right. But there's also the other end of it where you may just want something to work so your patients get better. And that may not happen. So you need to be able to be dispassionate about that outcome as well. That if this isn't working, let go of this intervention. And I think that's where the scientific method and evidence-based medicine is really important. It's not that there isn't leeway to step away from that in a pandemic. You can, and that's within the confines of a randomized clinical trial or any kind of clinical trial where you can try an experimental therapy and generate evidence. But I think this pandemic for me has highlighted the importance of following evidence.
Yeah, I think it has done that for not just clinicians and doctors and researchers at this point. The public at large is aware of a lot of things that were previously confined to just the field of public health and microbiology and medicine. And I think that's a great thing. I think not just researchers and clinicians, but all of us have learned a lot, especially as public, when it comes to evaluating evidence and evaluating guidelines and new scientific understanding. I think the past 1 year has been extremely insightful, as has this discussion. Thank you so much, Doctors Anup, Swapnil, Dr. Jayanthi, Dr. Aisha. This was very helpful, and I do hope the viewers who've been watching us also found this discussion helpful. We did have some questions, and I managed to incorporate them in our discussion as far as I could see. But if I missed out on some questions, or if you still have any further questions to ask us, please do ask us questions on social media. You could tweet to me, you could tweet to Dr. Swapnil, and we can try and get responses for you from all of the other panelists as well. Thank you, doctors, once again, and thank you so much, viewers, for tuning in.
Thank you.